I'm Dr. Hance Clarke. I'm a staff anesthesiologist and the director of the pain services here at the Toronto General Hospital. I'm a clinician scientist and I run a research program that looks at pain mechanisms. It looks at the transition from acute to chronic pain. We do a lot of opioid-related work. We look at cannabis and its effects on society and how that can be helpful potentially in pain. And pain medicine in general is just one of the most complex areas, I think, of medicine. It encompasses physiology, it encompasses psychology, it encompasses all of the pharmacological treatments that we can use. When you think about cancer and you think about having surgery or major surgical intervention, which many cancer patients have, it's not really well known that 20 to 30% of people will struggle with some pain up to about 6 months after surgery. And about 8% a year out have significant pain disability as a consequence of an intervention. And so when you look at the 200 million surgeries that are performed worldwide, that's a pretty big number that has an impact from a life-saving intervention that then needs supports to kind of deal with that. And so when I had finished my PhD in particular, there was a lot of research already empirically done on what are those risk factors, that go on to lead people to do poorly after surgery or develop chronic pain. But there was no service established in the world in terms of looking at how you go about helping those people do that. And can you actually modify that trajectory so they get back to their baseline a little bit sooner? And that's what we did in 2014 when we established our transitional pain service. And we've been lucky enough to have this really been taken up by the world and have many centers now across North America starting to build these programs and in Europe as well. I think it's become pretty clear that no matter who you are, you get a lot of resources when you enter the medical system and you have a diagnosis of a complex problem. And so whether you're having surgery, whether you're having chemotherapy, whatever it is you're entering, there are a lot of supports during that time and definitely during the surgical experience. But once you're done and you leave the hospital, those supports fall off pretty quickly. And it's pretty clear that the gap we're filling here is identifying people early on that are going to struggle and then giving them the appropriate resources to cope. And what's pain? Pain is basically a central nervous system signal going to the brain telling you this thing hurts. And your expectation is that you shouldn't have that after intervention, but for those who do have it, they really need to learn about it, learn about the mechanisms and really start to master it. And how do they do that? There are 3 main mechanisms of doing that. One is medications we can give you, 2 is exercise, physiotherapy, Pilates, yoga, you name it, and your brain. And all of these things have a role to play in dampening down that nervous system. And the people who do well long term are the folks that, put the pieces together of all 3 of these things and come up with a regimen for themselves that's individualized, and we can help you certainly do that. Hey, Bing, how you doing? So when we started this program, we were really tackling 2 things. One are the folks that go on to develop a chronic pain as a consequence of their surgery, and those that were struggling with opioids. We were in the middle of an opioid crisis. People are dying, and every part of medicine was trying to say, what's your role in this? And in the perioperative space in particular, there was certainly this belief or this thought that we were making people opioid addicts from giving them opioids post-surgically. We all know that opioid meds are excellent in the acute pain setting. It's how you go on to monitor folks and look for those who run into trouble. And the number really isn't that high. It's about 3% of individuals that remain on a medication at 6 months. And when we looked at Ontario data, it was probably 1.8% that stayed on those a year after surgery, okay? But you still needed to know that if you were prescribing medications that they may not be used, they may be being used by other individuals, etc. So we really developed one of the first guidelines around perioperative opioid prescribing right around the time of COVID, and also created some home induction protocols for folks that wanted to be weaned off their medications or were on really high doses of opioids that wanted to be transferred onto other drugs like buprenorphine, naloxone, some of the drugs that you can certainly use less of to help you move away from those medications. When we look at, I would say, some of the really cool data that we found, we can tell now very early on who's going to struggle. And so those that perceive their surgical journey to be traumatic will have a hard time. Anybody who comes in and they have real significant anxiety preoperatively. And so we've really identified some of these things that, if we can give resources to patients even preoperatively or very early in that postoperative course, when we know what those risk factors are for struggling. So using a ton of opioids, having high anxiety, really being traumatized, having a lot of psychological distress. If you don't bring all of those pieces together in a multidisciplinary team early on, that's where folks really run into trouble. What's your plan in terms of getting back to work or, moving forward?
Well, ideally,
I'll be honest with you, I think one of the most compelling things of the cancer journey is this belief that once you're through your therapy and you've been cured and you've had the cancer resected, that you go back to life as normal. And the fact is, if you're a woman and you have breast cancer and you have an estrogen positive type tumor, you're never going to have estrogen be part of your life again. And that changes you as an individual. And if you're a person, or if you're one of the 20 or 30% that go on to have a surgical resection and then have a consequence of pain or nerve symptoms that last quite some time, you're not going to return to that place. And the belief is that, oh, well, your cancer's gone and there you go. And so I think one of the really cool things about the program is that we see that, we understand that, and we do our best to support that journey, no matter where those folks are, and help them land in a place where they can use all of the tools that we touched on earlier in terms of using your brain, using your body, and using what we can do for you to get to that place. And one of the things we're really proud of, we were given some funding by the federal government to build our transitional pain service website, transitionalpainservice.ca, which was a resource for people around the world, policymakers, hospitals, institutions, to download this kind of how-to guide in terms of how you build one of these things. But I think the bigger things are, we have some patient resources that they can go and you can look at as a cancer patient and say, okay, so what is chronic post-surgical pain? How do I understand this? What is the aspect of psychology that is important? Because everybody's first gut reality, it's not my brain. Well, it's not that it's in your brain, but pain is an experience that comes from how you interpret those inputs. And so it certainly has a part to play in your brain, et cetera. And getting that message across is often something difficult. And so that's why we built some of these modules so that patients can actually sit down and just spend some time understanding these concepts even before they see us sometimes. So when you look at the transitional pain service in the program and you're thinking about scalability nationwide, I can tell you that Vancouver has built a transitional pain program at St. Paul's as well as Vancouver General Hospital. Alberta has taken it up as a part of their provincial health plan, actually, so that this is something that they'll support all Albertans as they move forward. When you look at Ontario, as north as Thunder Bay, have started to think about building these programs. And when you get to the, Quebec and the East Coast, for sure, some of the French-speaking hospitals, I think CHUM is also looking at replicating this. And so each one of those therapies come with a certain psychological impact. And so when you're left at the end of your surgical journey and you have, this overlay of pain symptoms, or you're stuck with your medications, understand that there are supports out there for you to head towards. And again, it goes back to the three tenets: what we can help you with as physicians and how you can help yourself. And that's typically, with a healthy lifestyle, exercise, and then how you go about learning mindfulness and meditation and accepting, your new life and where you are and how you go about living the best quality of life that you can with the years that you have left.